So we are starting our session 3 now. It's about interventions and post-conflict futures, which is very much related to the region's health problems at the moment. And we have 5 speakers in the session. We propose that each speaker will speak 15 minutes. Then we'll have questions for that presentation. Our first speaker is Martine Najem. She is from AUB. She is an instructor of public health practice at the AUB. She is an active member of Center for Studies on Aging and has been substantially contributing to the work of Center for Studies on Aging on older people in emergencies. In her current position at EUB, Martine is a member. She is involved on Help Age International project, and this project aims to implement NCD quality management among refugees and host communities. So she has extensive experience in public health and developing programs with UN agencies, international and national NGOs, and she has a master's in public health degree from the EUB. So, Martine.
Thank you. Good morning, everybody. I just would like to start by thanking the organizers of this very interesting conference and for giving me the chance to report on our joint collaboration with Help Age International. As you can see, the title of the presentation relates to quality management NCD programs, and we would like to answer the question of whether they have an impact in humanitarian settings. Unfortunately, and because of the realities of the grounds that has been addressed through the keynote this morning, we started off when we submitted the abstract wanting to report on findings of the evaluation. Today, and because of the many delays and challenges on the ground, we will be talking more about the actual evaluation challenges and obstacles that the intervention has faced, in the hope that this will bring some lesson learned in terms of similar evaluation attempts or projects in the future. And hopefully in the next RESCAP meeting or otherwise, we'll be reporting on the findings. Briefly, I'm going to start by a quick background on the intervention itself, the log frame, and the purpose, the overall purpose of the evaluation. Then I'm going to move to some examples of existing knowledge regarding either CVD interventions or interventions in humanitarian settings, and then talk a little bit about the project's M&E framework so that I can focus at the end on challenges in implementation and evaluation. As a quick background, recent reports show that around 54% of older surveyed refugees in Lebanon do have a chronic disease, and 30% of Syrian refugees in Lebanon report suffering from a chronic disease, which also shows some kind of discrepancy between the diagnosed and the undiagnosed individuals. This makes the management of non-communicable diseases a major public health issue in Lebanon, especially more so within the context of the humanitarian Syrian refugee crisis. Our project is, as you can see, has multiple partners, and those are AUB, Help Age International, Amel Association, Médecins du Monde, and YMCA. And each of these organizations have a different role in the implementation and following up on the project. And as you can see from the title and overall goal, it is meant to improve management of diabetes and hypertension at primary healthcare level, with, of course, the ultimate aim of contributing to decreased mortality and morbidity from chronic diseases among Syrian refugees. Our role as Center for Public Health Practice at the Faculty of Health Sciences at AUB is is to monitor and evaluate the project in order to assess its effectiveness and inform recommendations for scaling up the intervention, and I'll be going back to that in a while. Also, very briefly, the project log frame makes our evaluation mostly related to process and implementation evaluation. As you can see from the set outcomes for the project, it is meant to achieve a series of outcomes that are more on the short-term level. The first one being health facilities able to provide appropriate treatment and management of diabetes and hypertension, and then healthcare providers at those centers able to manage patients with hypertension and diabetes that come to the clinics and based on WHO NCD guidelines. Again, community members living in the catchment area have more awareness about such issues so that they seek the healthcare available, and then the patients that are seen and managed to actually comply with the proposed treatment and follow-up behavioral change recommendations. So to achieve those outcomes, there are a set of activities, and we've tried lumping them in three major components so that we all have a picture about how the intervention is designed. The HelpAge and other organizations are working on providing support in terms of equipment, even medication, lab tests, etc., to the AMED centers and mobile clinics. Also, training of healthcare workers on NCD guidelines, and again, training on both hypertension and diabetes. And also the awareness-raising component to increase response from the community towards seeking those health services. This intervention is currently being implemented in 3 sites, in Kamid al-Lawz, in Mashghara, and in Hayy Silom. And we have a combination of primary healthcare centers as well as mobile clinics. And I will get back to this in terms of difficulty in implementing and evaluating. Why do we want to evaluate this project? Simply because we have a few questions that we need to answer, hoping to feed in future similar interventions in such settings. The first one being, are NCD interventions effective in a context where healthcare centers lack resources? We all know the big overload that centers are facing with the influx of refugees, and there is some chaotic approach to different disease management and diagnosis. So we're trying to focus more on NCD interventions to answer this question. In a setting like Lebanon, where senior refugees are in informal settlements, not necessarily in camps or very precise geographical areas, can the impact of an NCD program be measured at all? This is also one of the things we'd like to look at. Also, an important component of this program is the capacity building of existing healthcare staff, being nurses or physicians. So we would like to also know the different effective capacity building activities that could lead to an actual improvement in performance and a better management of NCDs in humanitarian settings. Again, and as you will probably see in different presentations on refugee situations, on many occasions, if not most occasions, the host community is kind of left out, or whether in the intervention or even in the evaluation phase of any project. So we'd like to figure out whether there are some discrepancies between host and refugee communities and build on that in future designs. And of course, like any evaluation, it is meant to identify challenges and barriers that hinder the implementation of a quality management NCD program, especially adapting the existing WHO guidelines in complex humanitarian settings. Very briefly, to give us some perspective on what has worked and not worked internationally in such situations. For examples from NCD interventions, and I'm referring specifically to the Isfahan Healthy Heart program, show that usually the implementation and evaluation of a comprehensive, integrated, community-based program in a developed country is feasible and successful in obtaining short-term improvement in several lifestyle behaviors. Of course, this does not necessarily apply identically to a humanitarian setting, but we're talking about an NCD intervention in general. Another observation from the evaluation of such intervention is that usually the cost and complexity of evaluation makes it difficult to assess the impact of every component of the intervention. And we end up either evaluating the whole intervention in terms of effectiveness without going into the specificities of each component. And again, usually, ideally, having intervention and control communities also helps in doing more solid evaluations. Again, this is also might be a little bit challenging in humanitarian settings, especially with ethical considerations or with regard to geographical location of control communities in a mobile, very dynamic population. On humanitarian settings, am I pointing this in the right direction? Okay, in humanitarian settings, we did not find much about the NCD's interventions, but we drew some examples from reports on adolescent sexual reproductive health programs in humanitarian settings. And we were able to derive some best practices in successful programs that could easily apply to any humanitarian setting that we are considering and any other health issue like NCDs. Stakeholder involvement has proven to actually be a key factor in success in terms of building communities' trust and securing adult support, and this is adult vis-a-vis adolescent in this case. Another important best practice relates to actually catering for different subpopulations. Our project caters mainly for older adults in terms of NCD management, but also catering for subcategories within the same target population, whether married or unmarried, in this case, in school, out of school. Of course, gender differences and adolescents with disabilities would make a program more focused and an intervention more effective. Of course, the staff usually is a big factor of success in terms of ability to deliver the intervention. Same applies to the recognition and mentorship. I will have to go quickly here, just saying that why interventions succeed or fail mainly because of low commitment or lack of involvement of the community members themselves addressed by the intervention. I have to count extra minutes for the pointer being ineffective. Okay, the framework we are using is, can we go back to the framework we are using is mainly the CDC framework on evaluating programs, and it includes various steps that rely mainly on engaging all concerned stakeholders in the process, and starts with the most important factor, which is describing the program. And this is where we have had some difficulties in actually moving on this. The standards of evaluation go around utility, feasibility, propriety, and accuracy. And I will not go into the definitions of these because of the lack of time. This is just to show you the framework we are focusing on. Now, the core of my talk would be about challenges to implementation and evaluation. And in the intervention, as many interventions that are with the international donors, there are logistics issues involved in terms of ensuring delivery of medication on time for the intervention to start. So this was an issue for us. The NCD guidelines that we are using are unfortunately the 2006 ones because we couldn't get the most updated from the Ministry of Public Health. Again, I talked earlier on the discrepancies between centers and mobile clinics, so even the intervention had to be tweaked to account for those discrepancies and for the type of population addressed. The outcome of trainings for doctors and nurses proved to be a little bit unsatisfactory, so we had to go to the extra mile to do one-on-one trainings to ensure that doctors and nurses are ready to engage. And then security issues in the Bekaa area, especially with the blockage of the roads, made it difficult for staff to reach there. And of course, the always figuring their challenge of workload and limiting resources during peak times. In terms of M&E process, all these delays or challenges in the intervention has to impact actually the MNT. The difficulty in defining evaluable outcomes whenever there are such changes in the intervention. And again, the project that was supposed to start sometime in July or August was just launched because of all these challenges, which will in turn, of course, launch the implementation of evaluation activities. M&E challenges are mostly related to the ability to align project activities to objectives, because sometimes even if the intervention is well designed and well set to start, whenever we go on the ground in such a difficult, complex setting, things will need to be changed and adapted, and this will impact, of course, the objectives that were originally set. The uncertainty around those activities made it necessary to start testing what works, what doesn't work in terms of referral, lab tests, medication, how do we deal with the patient. So this also has impacted the MNT. Again, targets apply the same way to the activities. And then a major MNT challenge is the lack of baseline data, because again, the luxury of making full assessments pre-intervention do not always exist in such settings, and people are very eager to start the intervention because you want to serve a population that's already very much in need. The limitation in time frame of the project, which is also related to the limitation in funds, makes it difficult to observe actual medical outcomes in terms of improvement of diabetes or hypertension, which we all know take more time to develop and to be observable and measured. The last 2 points are about the low literacy of the target population and existing documentation, record keeping, and reporting mechanisms, which also made us be more creative in terms of developing the potential tools to measure the outcome or the process. And again, as always, and even in humanitarian settings, concerns of ethical nature related to wanting to make it work before starting to measure whether it works or not. So we were very keen on delaying the launch in order to make sure we are ready to actually intervene and provide minimum quality services. We are hoping to use this result, this is my last slide, to advocate at the national and the regional level for the inclusion of NCD programs in humanitarian programs, and to scale up the NCD management programs, both feeding into the intervention design and the evaluation design. So we know we will be able to report on what is evaluable, what is not evaluable, what are the methods that work in such a setting, and what are the monitoring tools that are most effective. We are hoping to feed into a bigger scale-up project that would be at the national or even at the regional level, both in designing the intervention for the scale-up and also the evaluation design. I think I'm done. Thank you.
Thank you, Martine. I think we used a little bit more time than we were supposed to, so maybe we can take the next speaker.
Just 3 minutes, maybe.
You want me to stay here or there?
Well, won't you be?
Will you be there? Okay. So we can have questions for the
Can you tell us about some of the challenges you met with nurses? What were some of the issues? And the doctors, but specifically the nurses, I'm interested. We at the Order of Nurses, we're launching an initiative, a campaign one of a kind, the first time initiative to promote the role of nurses in public health. So that would help us actually, work on our project too. Thank you.
Would you like me to take them one by one, or?
There is Fuad and Samir, and then this will be, yeah.
Yeah.
Go ahead, Sam, since you have the
Thank you, Martin. It's very interesting. Just my question is there any component for evaluate the referral system in that regard? I mean, and if there is feedback for that, thank you.
Thank you. This is an important initiative. How do we make sure, even as we push forward for a better integration management of NCDs and primary healthcare, that we do not promote a vertical approach, but rather focus on the big prize, strengthening primary care to deliver NCD and other care?
Okay, I'm going to start by the question on nurses. Thank you, Helen. Actually, The training results were a bit different with nurses and doctors. The only problem we're facing with nurses is the overload. It is not really the qualifications. So the nurse has sometimes to do 200 things at the same time when a patient comes in, and the patient, when coming in, doesn't even know if they are coming in for NCD issues or they could come in for a headache and the nurse has to screen and then say, well, this is part of the NCD intervention. This is why it makes it very hard for them to account for this overload. We are trying to figure out some kind of task distribution between the physician and the nurse and the social worker who is at the center. They also have a role to play in educating the patients, which also increases the burden on them. So all this is still being defined so that we make sure we are reasonable in the workload we expect from them. For your question about the referral system. Actually, the intervention itself includes a component whereby patients who are positively screened for NCDs are given treatment and medication and a follow-up appointment or visit. The referral at this stage is mostly for the lab testing because not all centers have facilities to draw blood samples and effect lab tests. And for the mobile clinics, it's even more complicated because we have to use the machines for home use, whether to measure glucose or otherwise. So the referral after to a specialist is not included in the intervention simply because of lack of funds and simply because the physician on site is a general practitioner. So we are limiting ourselves to actually recommending a follow-up measure and following up on medication. Samer, the broader question on making sure not to work in silos whenever we integrate NCD programs is actually an important question for all humanitarian actors. Every agency is trying through its mandate to push towards including some kind of topic or health issue or concern in certain programs. And we have seen actually local NGOs struggle with different programs being either imposed or proposed by other organizations, international organizations, or UN, or otherwise, to push in a certain direction. Unfortunately, this is, in theory, the role of the common task forces or clusters that coordinate those efforts. But as we well know, this is we are not in the best case scenario in terms of coordination and making sure not to overlap and complementing each other in different interventions. NCD in particular can be looked at as a topic that can, under its umbrella, attract different other health issues, specifically pertaining to behavioral changes and healthier lifestyle. I'm not sure whether this can be combined with other issues based on a target population approach. So is it better to unify interventions for a certain target group or actually address different target groups in the same intervention? This is probably a question that such evaluations or others can help answer.
Okay, thank you,
Could I just clarify something about the health ages? Can I just clarify something on the training? I'm from Health Age Regional Health Coordinator. The training, in fact, yes, we have some gaps in terms of medical training and refresher training on NCD practices, and then what happens when they go in the clinic and practice. So I just want to re-emphasize that we are addressing this issue for some of you who are asking about doctors and training through refresher training on site, which we believe will make quite a big difference. Thank you.
Okay, thank you for clarification.